If I could have your attention back here now, please. Thanks very much. Okay, so here we are, session 5 of today's workshop, and we're on the home straight. It was pointed out to me during the break that while I'd mentioned that there were 3 emotional styles that were highly relevant to the causation and maintenance of chronic pain, I'd actually only discussed 2 of them. So I'd like to just take a few moments now to discuss the 3rd one, which I think is highly relevant. And again, these refer to the emotional styles as detailed by Richard Davidson, a neuropsychology researcher, in his book called The Emotional Life of Your Brain. The first 2 emotional styles which I think are relevant to chronic pain are the outlook style, which involves positive emotionality or negative emotionality, and the resilience dimension, which involves either the ability to bounce back after adversity fairly quickly or the slow to recover end of that dimension. The 3rd one, which I think is relevant for chronic pain, is the self-awareness dimension. And this dimension relates to the ability for introspection, and it's relevant for both an awareness of feelings and physical sensations which give rise to our emotions. So some people are extremely unaware of their own sensations and feelings, while other people are painfully over-aware. And people that are suffering from chronic pain tend to fall into this latter group. They tend to be painfully over-aware, oversensitized, over-tuned into every cue for pain, every sensation going on within them, and of course this over-awareness leads to a heightened focus on the pain, and that becomes problematic in itself. One of the characteristics of people suffering from chronic pain is this heightened level of sensitivity to pain and discomfort. And the Pain Vigilance and Awareness Questionnaire, which I've included as Appendix 1 in the Hidden Psychology of Pain for you to fill in, assesses people's levels of hypervigilance in regards to their pain. So how focused you are on every aspect and every variation in your pain. High scores on this scale have been linked in research to pain intensity and to psychological distress from pain, as well as to high levels of psychosocial disability from pain. So people who score high on this scale would also score high on the self-awareness dimension, because it's basically assessing the same characteristic. Now, the brain area highly related to self-awareness is referred to as the insula. And this is located between the temporal lobe and the frontal lobes. So the temporal lobe is on the side of the brain, the frontal lobe is obviously at the front of the brain. The insula, especially the insula in the right hemisphere of the brain, is also highly involved in the experience of emotional as well as physical pain. So when we step on a nail, the insula is going to be highly involved, but also when we experience social rejection and the pain that goes with the emotional pain that goes with social rejection or the end of a relationship, the insula is also going to be highly involved in that. And it kind of shows this connection between emotional pain and physical pain and how these are neurologically highly related to each other. Now, the insula contains a map, a body map, which registers what's happening in each of the internal organs. So the heart, the liver, the colon, the lungs, the stomach, the kidneys, etc. And the insula also sends messages to these organs, instructing them to do things. So maybe the message goes to the lungs to breathe quicker or to the heart to pump faster. Higher insular activation is also associated with greater awareness of both physical sensations and emotions. Now, this is fine to have a high level of self-awareness. It's usually viewed as being desirable. However, it can spill over into hypochondria and also into panic attacks when excessive, and I would suggest also that it feeds into the chronic pain phenomenon as well. As I said, it also poses a problem when you're in chronic pain, as chronic pain is associated with hyper-awareness of every little change in bodily sensations. It's part of the chronic pain profile. Now, the insula, along with part of the brain called the orbitofrontal cortex, which is, again, it's in the front of the brain, just behind the eyeballs, as well as in association with the amygdala, part of the limbic system, which is highly related to strong negative emotions. So the insula, along with the orbitofrontal cortex and the amygdala, form a circuit which gives an emotional value to thoughts and sensations. The right frontal insula is where conscious physical sensations and conscious emotional awareness co-emerge. It's active when you experience either physical or emotional pain. So you detect both the state of your body and the state of your mind via your right frontal insula. And as such, you can consider it to be where your mind and your body unite. And this happens as a result of the strong connections between the insula, the amygdala, the orbitofrontal cortex, and the anterior cingulate cortex. And the anterior cingulate cortex allows you to monitor your behavior for mistakes. It corrects and avoids errors, evaluates context, plans and carries out actions that have emotional and motivational significance. And the anterior cingulate cortex is also highly involved in the experience of pain, and it appears to be the brain module which teaches the rest of the brain to do chronic pain. If you want more clarification about these brain modules, then refer to, I think it's Appendix 2 in The Hidden Psychology of Pain, where I go into a fair degree of detail about these different elements and parts of the brain and the different functions. Now, if you recognise that because you're in chronic pain, you have a too high level of self-awareness, you may choose the following approaches which are designed to settle down your insula. So cognitive behaviour therapy, CBT, can be useful in helping you to reappraise the significance of internal bodily cues. You'll also find in my book, The Hidden Psychology of Pain, essential bits of information from a small publication that was put out, at least in Australia, by the Victorian Work Cover Authority during the 90s, called the Back Book. And the Back Book is based on a similar publication that was devised in the UK. And the messages in the Back Book are an excellent example of this cognitive strategy. And you can find those on page 158 of The Hidden Psychology of Pain. As an example of the really important messages of the Back Book, one of the statements in there which is emphasised is that pain does not mean damage. So we can have pain for all sorts of reasons, and none of those reasons may involve damage whatsoever. So you have a choice to interpret a sensation in your back as a danger signal, which could be for you foretelling doom for your spine, or you could view it as yet another innocuous sensation which is related to a painful but essentially harmless condition, what we're referring to as TMS. In fact, all of Sarno's books, as well as my book, are examples of cognitive change strategies in relation to chronic pain. And the suggestion obviously is that you read them, you absorb the messages, and you can become confident that in doing so you're actually creating some of the neurological changes necessary for settling down your insula, which is necessary for pain reduction. An additional strategy for decreasing your level of self-awareness is to decrease the rest of the brain's reactivity to the messages which come from your insula. In particular, the goal is to reduce the activation of the amygdala. Remember, that's a fear centre of the brain, and the orbitofrontal cortex in response to the messages from the insula. By reducing the level of activity in this circuit, your brain can start to perceive bodily sensations in a less harmful manner and begin to see the reality that hurt doesn't mean harm. So your self-awareness will still be present, but you won't be hijacked by it with increasing emotional and physical pain. Meditation and mindfulness, which I discuss in chapter 17 of my book, and awareness of the present moment are all effective means of reducing the activity of your amygdala and the orbitofrontal cortex. The goal is to quieten your mind to the extent that you can simply observe various thoughts or physical sensations as they arise and fall without attaching a great deal of importance to them. This non-judgmental perceiving can result in breaking the chain of associations which have developed around your back pain and the notions of that pain reflects serious damage. So rather than responding to a flare-up with, "Oh no, this means that my spine is getting even worse," with the aid of meditation and mindfulness, you can develop the ability to respond in a more detached manner with something like, "Oh, a signal from my back has just reached my brain." There are many benefits to meditation and mindfulness practices, And some of these benefits are seen particularly with long-term practitioners of meditation. However, there really are very quick benefits that accrue to people from beginning to develop the practice of meditation. There's a whole bunch of excellent reasons to be to begin this practice of meditation, and the longer that you persevere at it, the more these benefits will accrue to you. So, as with the other emotional dimensions, there are also things that you can do to have an impact on the self-awareness emotional dimension via changes in your environment, because our brain is highly reactive to our surroundings. So you can make changes that you have more external stimuli to focus on, such as leaving the TV or the radio on in the background. You can be willing to multitask, that you have less neurological resources available for focusing only on your inner sensations. Obviously, when people just simply sit around, they've cut themselves off from many other forms of stimuli, and they just sit around focusing on their internal bodily sensations, and when that's a painful set of sensations, then they're just going to become even more frightened by it, which is going to get more activity going on in the amygdala. So if you multitask, you make sure that you're busy and engaged in other kinds of activities which absorb your attention, then it's basically leaving less neurological resources available for focusing on the physical sensations, particularly the pain. So in a nutshell, avoid sitting around doing nothing. Be active and ensure that your attention is captured by what you're doing. Okay, so at that point we'll leave Davidson's emotional styles behind. And I guess the important message to take away from all this is that with a greater awareness of what's going on in our brains, we're actually able to create brain changes which will foster this movement away from chronic pain. And our brain is doing all these things anyway, so we may as well get a handle on the different kinds of brain activities that are either going to foster chronic pain or foster a movement away from chronic pain, and choose to consciously use these approaches so that we can harness their healing abilities. When we finished up in the last session, I was discussing why this approach may not be taken up by people, and I mentioned the lack of communication between psychology and the physical therapeutic professions. Also, just to pick up on that discussion again, many of the physical disciplines basically deny the significance of psychological factors in the causation of chronic pain. Sometimes they're going to deny this purely out of ignorance, in that they simply haven't come across these notions before. And as I state in my book, ignorance is no crime. I was largely ignorant, well, entirely ignorant of these notions until I learnt about them, and I don't consider that to have been a moral failing. There are many psychologists that are still extremely ignorant about these ideas. And again, that's not a moral failing. And I guess if there are many psychologists that are ignorant of this approach, then it's more forgivable that physical practitioners, physicians, chiropractors, physiotherapists, etc., who have focused on the body, that's what their discipline has trained them to focus on. It's perhaps even more forgivable that such people would be simply unaware of the significance of psychological factors. I don't think ignorance is a major problem in a health professional. It's not a great thing, but of course there are things that we're all ignorant about. It's fairly universal. The more worrying problem is arrogance, where any particular kind of health professional believes that they have no need to learn of other information, and they've dismissed that information up front. If your health practitioner, whether it be a psychologist, a GP, physio, chiropractor, etc., regardless of their discipline, if they display this kind of arrogance, then it may be an indicator that you're not working with the right person, particularly if you want your health practitioner to learn of important information which could be really essential to your recovery from chronic pain. Other practitioners, health practitioners, believe that they would be doing their clients a disservice if they suggest a psychological approach. Some people can be highly offended by the notion that there are psychological factors involved in their chronic pain, and they may react in a highly defensive and maybe hostile manner if their health professional suggested this to them. Of course, it really all depends on how the health professional suggests these ideas to people. The worst thing that anybody could possibly say to anybody suffering from chronic pain is, well, it's all in your head and you need to just think differently to get over it. This can be a really harmful message for people to receive. And again, even though the health professional may be roughly heading in the right direction, their means of communicating this is probably an indicator to you that they don't have the level of understanding or empathy required to actually help you. And again, you may be better off looking for another health practitioner that has a greater level of empathy and understanding. Let's see. Okay, now I'm just going to throw in bits and pieces of information here at this point of the workshop, which I think are important for people to gain an understanding of. Professor Sarno's research, his clinical outcome research, shows that around 88% of his patients got better, got over their chronic pain as a result of purely processing information. Now, of the 12% that didn't get better, these people were referred to work with psychologists that worked at his centre. These psychologists use primarily a brief psychoanalytic approach to therapy, which is kind of more based on Freud's notions of psychoanalysis. But this approach has been modified with, nearly another 100 years of evolution in psychoanalytic thought, and modified in terms of making them brief as well. So it's not pure psychoanalysis that these people are treated with. And what the research shows is that the vast majority of this 12% of people that didn't get better just with purely processing information, the vast majority of these people actually then got better as a result of the additional psychological assistance that they received from the psychologists. There's around 1 to 2% of people didn't get better, and the assumption is that maybe these people were suffering from a higher level of trauma that probably requires a more trauma-specific psychological approach, or that these ideas simply weren't resonating with where they were at that particular time or that part of their journey of chronic pain, and there may be another time in their lives when these ideas may be more beneficial to these people, or these people require more trauma-specific psychological therapy. A common feature of pain management programs is to get people exercising again, get people to become active again. Now, typically people that are in chronic pain want to be active, but they've learnt to be highly frightened of activity, physical activity, as a result of trying to do some gardening or trying to do something in their workshop and experiencing a great whack of pain. And they become classically conditioned to feel fear whenever the notion of being physically active pops up within them, or whenever they try to be physically active. There are ways of going about increasing your activity level. One important thing to realise is that if you're suffering from ischemia, the oxygen deprivation of muscles and nerves, it means that your muscles are actually more vulnerable to being torn, just by virtue of the decreased amount of blood and therefore oxygen in the muscles. And as a result, it doesn't make sense to then run out and think, okay, well, I've internalised these ideas about TMS. I'm going to be thinking psychologically about overcoming my pain. I'm going to follow all the strategies, etc., creating room for the negativity in my emotions, etc. And therefore, it should be okay for me to go out and lift some heavy weights while you're still in pain. And I'd really advise against doing this. If the ischemia is still functioning within your body to such an extent that you're still experiencing pain, let's say in muscles in your back, then putting a great workload on those muscles is simply going to increase the chance of you tearing those muscles. There's a reasonable chance that your muscles would have suffered from an atrophy as a result of disuse, so they're simply not used to the form of workload that you used to put on them. And as I said before, just by virtue of having a decreased blood and oxygen supply to the muscles makes them more vulnerable to muscle tearing. And if you go out and you lift some heavy weights while you're still in pain and you experience a predictable dose of pain as a result, then all you've done is reinforce this notion that exerting myself is going to produce pain. And that's not a terribly helpful notion at all. It's going to take you further away from increasing your activity level. The suggestion in terms of improving your activity level is to hold off the resumption of your pre-pain activity level, whether it be vocational activity, the kind of physical actions you need to do for work, or recreational activity, until your pain is in remission. And then when your pain is in the process of decreasing, then in small bits and pieces gradually increase your activity level and your exercise level. Now, when you're in the process of increasing your activity level, again, the emphasis is on doing it gradually. Don't run out and expect to lift heavy weights again immediately just because your pain level has decreased. You need to engage yourself in a process of pacing. And pacing is the idea that we need to be gradually increasing the activity level and the workload on our muscles that have suffered from a decrease in activity over a substantial period of time. And what most people in chronic pain do is they engage in what's called the boom or bust cycle. So on the days that they feel pretty good, and there might be an exception happening to their normal pain, they think, new beauty, I can get out there and mow the backyard and do some of that landscaping that I've been unable to do for the last 3 or 4 months, and move some heavy sleepers around and move some wheelbarrow loads of dirt and bricks and rocks, etc. And they may succeed in doing that for a couple of hours or half a day or even a full day, but because their muscles are still suffering from ischemia, even if to a lesser degree, and because their muscles have suffered from a disuse atrophy, then there's a pretty good chance that they're actually going to increase their pain as a result of this great amount of work that they've done. And as a result of being in increased pain, they may have torn muscles, they may simply create a stress in the muscle because, again, the muscle's still not getting the amount of blood and oxygen that it needs because you're not entirely cured from TMS as yet. And they may have pulled muscles in their back or their shoulder or their neck. And because the person experiences an increase in the pain, they may again be highly fearful and feel extremely bad about being in pain, emotionally very bad, and catastrophize about it and think what a terrible thing it is. Here I am back at square one again. I thought I was getting better, and how dreadful it is that I'm back to square one again. And as a result of being in pain and catastrophizing about it, they may wrap themselves in cotton wool for the next week or 2 weeks until the pain begins to settle down again. It takes, roughly a couple of weeks for muscle tears to recover. And of course, over that week to 2 weeks of being inactive, all they've done is increase their disuse atrophy of the muscles again, and they haven't increased their hardiness, their muscular hardiness whatsoever. And maybe in 2 weeks' time, they wake up and they think, well, I'm actually feeling pretty good today. I'll get out and I'll have another crack at that backyard landscaping job again. And they do the same thing again. So these people tend to cycle between a boom and bust profile where they have extreme bursts of higher levels of activity. Then they spend the next week or 2 weeks suffering enormously as a result of that heightened activity level, in which time they sit around and they do nothing and they catastrophize, they feel emotionally dreadful, they feel physically dreadful, and there is no gradual increase in their activity level as a result. They just bounce between these two different extremes. Pacing is the opposite option, and it's the preferred option. Now, pacing is the notion that you work out, let's say if you're suffering from extreme back pain, it's been with you for years. You work out for yourself, even on the worst days, what is the amount of activity, let's say walking as a gentle activity, what's the amount of walking that I can do that's not going to make my back pain feel even worse? And you might decide that the most walking you can do is 3 minutes. Anything above 3 minutes, your back pain is going to increase. So your task for the next week is to walk for 3 minutes every day, regardless of how you feel. Now this includes on the days where you feel pretty good and you reckon you could easily walk for 20 minutes, but the suggestion is you stick to walking to only 3 minutes. And also you stick to walking only 3 minutes on the days when you're feeling really awful. So on the worst pain days. Every day for the next week for 3 minutes, every day you walk for 3 minutes. And what you're doing is slowly building up your muscular hardiness. A week later, you reevaluate how much can I walk, even on the worst days, without making my pain a whole lot worse. And you might decide, well, I can actually walk for 8 minutes. So every day for the following week, you walk for 8 minutes, regardless of how you feel. The following week, you reevaluate again, and so on. Every week, you're reevaluating and you're adding additional amounts of workload to your exercise regime. And what this does is it creates a constant upward curve in your level of activity. And in so doing, you're gradually overcoming your disuse atrophy of the muscles. You're increasing the hardiness of the muscles. You're giving them more opportunity to exercise and to develop a greater level of fitness. You're doing it in a gentle enough manner to not cause any muscular tears, which will set you back. And as a result, you're not giving yourself any failure experiences with exercise. In fact, you're only giving yourself a whole series of success experiences, which goes a long way to retraining your mind/brain's perception of exercise as being a safe activity, as being a safe thing for you to do. And it begins to take out some of the fear from physical activity, which is really very essential. So it allows you to gradually redevelop a confidence in your body and your ability to use your body. Now, it doesn't have to be restricted to walking. You may do this with any form of exercise. It could be swimming. It could be using weights in a gentle manner and starting off with a low level of weights and using those low level of weights every day for a week, and then slowly increasing the weights that you're using. It could, if you're up to running, you could do it with running and distances that you're running, etc. It could be the amount of time that you spend gardening if it's a fairly consistent kind of activity. If, for example, you're pulling weeds out every time that you do it, or using a lawnmower or a brush cutter. So you can work out, there's a multitude of ways of incorporating this pacing notion into an exercise regime that will allow you to, in a gradual and gentle manner, to increase your activity levels, which is really what's essential to overcome the muscular atrophy through lack of use, and to rebuild your confidence in your body's ability to cope with physical activity. And of course, our body is designed for movement. We need to be moving. If there was nothing wrong with your body at all, if you experienced no acute or chronic pain, but you just chose to lay down for days on end, you would end up being in significant pain. Our body is actually designed for use and movement. Regardless of our age, it's what we're physically equipped to be doing. So being completely inactive, while that's the temptation when you've got chronic pain going on, it's probably one of the worst things that you can do, and being active is one of the best things that you can do. But we do need to be active in a smart way, and pacing is that way of going about that. Okay, I mentioned that the psychologists that work at Professor Sarno's centre use brief psychoanalytic approaches to their therapy, and they help the majority of people get over their chronic pain as a result of that. There are other therapeutic approaches, psychological approaches, which are very important and can be very helpful. And the world is a marketplace of ideas, and there's all sorts of different therapies available. So I just want to give you a brief sketch of some of these that I think are useful. I've already mentioned meditation and mindfulness approaches to psychological development, which are potentially very helpful. You can learn meditation through any number of books. I'm sure you could learn it through YouTube video clips. And no doubt there are many instructive web pages on the net that could help you. You can learn meditation through meditation groups, probably at community health centres, etc. Cognitive behaviour therapy, CBT, I think can offer some degree of help, but because it's basically not a depth psychology approach, I think it's limited in the level of help that it can offer. It can certainly help with things like catastrophizing about pain and trying to minimise the amount of emotional distress associated with pain. CBT could be helpful with that, but I do think that it's of limited use when it comes to chronic pain. It could be very helpful with a range of other problems, but when it comes to chronic pain, I think its ability to help is of limited use. This is unfortunate, as most psychologists that are providing services these days are purely providing CBT, which means that I think their ability to assist with the treatment of chronic pain, unless they're willing to take on board ideas that what I've been presenting today, are actually quite limited. There is a new development in cognitive behavioural therapy called acceptance and commitment therapy, ACT for short. And acceptance and commitment therapy is quite different, even though it's still a cognitive psychology approach. It has more of a depth psychology element to it. And there are ACT programs that are devised purely to help people in chronic pain. You may like to make inquiries with your local community health centre, or if your local hospital has got pain management programs, they may very well offer an ACT pain management program, and I think that could be quite helpful. You will probably also find some local hospitals or community health centres may offer mindfulness programs. Now, the research shows that mindfulness programs can help to reduce the intensity of pain. There's only a minority of people that go through mindfulness programs wind up becoming pain-free as a result. But mindfulness programs that incorporate meditation as well as a range of other practices can certainly be helpful in reducing, again, the catastrophizing and the whole level of emotional arousal that goes along with chronic pain, the fear, the anxiety, the depression that goes along with chronic pain, which all feeds back into the pain pattern as a psychological overlay. So mindfulness programs and ACT programs can be very helpful. I mentioned early in my book that I underwent a rebirthing process. The rebirthing is a particular type of psychotherapy which sounds like it's all based on the idea of going through your birth process again. It's probably an unfortunate title for the approach, because rebirthing may or may not involve re-experiencing your birth process. I did a week-long residential workshop in rebirthing as a participant, and at no time did I go through a re-experiencing of my birth process. But I did go through re-experiencing very significant traumas in my life, particularly my car accident when I was 18, and I found it an incredibly cathartic experience. It involved a whole lot of howling and shouting and screaming and all that kind of stuff. It was a massive unburdening of a storehouse of distress that had been in me ever since I was nearly killed in my car accident. And I certainly felt significantly lighter and emotionally better as a result of that whole experience. However, I didn't get over the chronic pain that I had in my left groin. So while I found rebirthing an incredibly psychologically helpful experience, and I suspect it really did help with my emotional trauma from my car accident, in of its own right, it didn't actually help me to get over the chronic pain. And this leads me to the view that there's a whole range of very effective psychotherapies out there, and most psychotherapies are actually effective. Research shows that 80% of people that undergo psychotherapy of one form or another are better off than people that have the same problem that go untreated. So the research amassed over the last 40 years clearly shows that psychotherapy is very helpful, and most forms of psychotherapy are kind of equally helpful in most forms of psychological problems. Now, the impression that I've developed is that a lot of these approaches to psychotherapy, like Gestalt therapy or rebirthing or mindfulness or ACT or CBT, can be helpful in overcoming chronic pain, but I don't think any of them are going to actually go the whole way in eradicating chronic pain, simply because none of them have an awareness of the internal psychological dynamics which are responsible for producing the chronic pain. So all these different approaches can be helpful, but without attaching to them the approach that I've been describing you today, I think they're all actually limited in their ability to resolve chronic pain. They may reduce the chronic pain. They will more than likely reduce the emotional turmoil that people experience around chronic pain. But in their own right, I think they're all somewhat limited in terms of getting rid of or eradicating chronic pain. Now, any of them, I think, could actually achieve this if they be combined with the kind of suggestions that I've given you today. If they're combined with what we might call the TMS model of psychogenic pain, then I think any of these approaches, mindfulness, ACT, meditation, Gestalt therapy, cathartic approaches like rebirthing, etc., all these approaches, when combined with the TMS model, can achieve excellent results in eradicating chronic pain. And on their own, I think they're all limited in their ability to do that. Now, if somebody's chronic pain is resulting from trauma, and keep in mind, I said before, earlier today, that trauma exists on a continuum, where you have the big T traumas up one end, the most extreme and dramatic types of traumas, through to the small T traumas, the less dramatic, less extreme type down the other end. If your chronic pain is resulting from trauma, and it could result from either big or small T traumas, then I think a psychological therapeutic approach which actually addresses the trauma is essential. Now, it is possible to overcome chronic pain just with utilising the TMS model, by internalising the messages that I've given you today, immersing yourself in these ideas, absorbing these ideas over a period of time, reading the books, doing the journaling, answering the self-analysis questions, talking to people about it, getting as much information as you can about it, listening to recordings like this over and over again. I've seen it happening often, in fact repeatedly, that people are able to get over chronic pain just by processing information. I succeeded in doing this, and many of my clients have succeeded in doing this. In fact, the first client that I discuss in my book, Max, chose, the man that suffered from sexual abuse from his brother throughout his childhood, chose not to address the psychological trauma associated with that abuse, and he managed to get over his chronic pain. Now, I think he may have been far less vulnerable to repeat attacks of pain had he chosen to address the psychological trauma, but that wasn't his choice. He didn't choose to undergo that psychotherapy to do that, and I needed to respect his choice on that matter. When people are suffering chronic pain, which is underpinned by emotional psychological trauma, my suggestion and my preference is for people to undergo trauma-specific psychotherapy. Now, there are two types of psychotherapies that fit this bill. One is called exposure therapy, and the other one is EMDR, eye movement desensitization and reprocessing. EMDR has a lot more evidence in its favour that it works very effectively in treating people's trauma than does exposure therapy, and as a result my preference is to use EMDR with people and to advocate its use with people suffering from chronic pain. EMDR it's a very big discussion in its own right, and if not yet, then shortly my webpage, my webpage already has information about EMDR. It has printed information about EMDR with links to interviews with Francine Shapiro, the American psychologist that devised EMDR. And there are links on my webpage to both written interviews where you see written, typed out questions for Francine Shapiro and her written responses. And there's also a link to an audio interview with Francine Shapiro in which you hear her discussing EMDR. And I really urge people to use these resources to find out what EMDR is about. If not already, then at least shortly my webpage will also have 2 video presentations that I've done in which I explain EMDR. Now, I've prepared these primarily for clients of mine that I'm seeing in person, and I'm going to be taking them through an EMDR process. So it's geared towards people who I'm about to see to continue with the preparatory groundwork for doing EMDR. But if you're wanting to learn more about what actually happens in an EMDR session, then both of these video presentations will be quite informative for you. Okay, now when EMDR is combined with the TMS model, then personally I think it's a perfect combination that more often than not produces excellent results. Obviously, the experienced psychologists that work at Sarno Center in New York find that brief psychoanalytic therapy combined with the TMS model is also highly effective. I just am simply not trained in brief psychoanalytic therapy and I don't offer it, so I really can't comment on it other than to say it's obviously effective. Another notion that's very important is from a particular psychological therapy called solutions-focused brief therapy. And the notion that's important here is the notion of exceptions. Now, as we know, every problem has its exceptions. So every problem has its problem rule, such as, this always happens to me when I take this particular action. That's the problem rule. And as with every other problem in existence, pretty well every problem rule also has its exceptions. Now, people in chronic pain tend to have a lot of problem rules. So whenever I lay on the couch and fall asleep while I'm watching TV, I wake up with a very stiff and sore neck or back. Whenever I don't sleep with the right kind of pillow or on the wrong sort of mattress, I wind up in extreme pain. Every time I lean forward to brush my teeth, I get a stabbing pain in my back, etc. We all have these problem rules that relate to our experience of chronic pain. Now, the notion of exceptions is extremely important here. Every problem has its exception. Now, if you choose to look for it, you will find that there are times when either your pain, despite having performed the normal offending action, when your pain is either far less than usual or, in fact, it's non-existent. So the person that wakes up once every day in 2 weeks and says, "You beauty, I'm not in pain," is experiencing an exception to their pain pattern. And in the exception are extremely important messages. There's a couple of dramatic cases of exceptions which I've included in my book. One was of a woman who, when I met her, was in her early 30s, and she was born with what's conventionally called a hunchback. So her spine resembled a question mark shape, and it was congenital. She was born with it. Now, she reports that in her childhood she underwent about 6 surgical procedures, operations, in order to try to correct the deformity of her spine, and none of these procedures worked. And as a result, she became a school kid, and then a teenager, then a young adult, with this extreme physical deformity of her spine. And she reported to me that she's always in pain. She's never not been in pain. When I asked her if there were any exceptions to it at all, she reported 2 really important bits of information, which actually indicate perhaps what was going on for her. Firstly, she reported that the pain didn't start for her until she began primary school. And this means that while she was under the care and the nurturance and support of her family, primarily her mum, her family was able to buffer her against the stresses of prejudice that exists in our society against people with some kind of physical disability or deformity. So her family was a safe, nurturing environment for her, and she was treated as a highly valued person just because of who she was. When she got to primary, and she was in no pain during that time. When she got to primary school, for the first time in her life, she was subjected to ridicule, teasing, tormenting from her peers. She was exposed to the wider world, and even sometimes adults would stare at her, and she was treated very badly, basically. And this is the time in her life when the pain began. And of course, it was a time in life when her emotional pain began. Now, the exception is from 0 through to 5 or 6 when she started primary school of not being in pain. The other really important exception to her pain rule was she told me that a couple of years earlier she'd spent a year overseas in a European village. And rather than being viewed as a freak with a hunchback, as she was viewed in her own country town, in this European village, she was viewed as being something of a celebrity simply because she was from somewhere else. Fortunately, she had the language of this part of Europe, so she could converse with these people. And she was viewed as being special because she was from a different part of the world, and they viewed Australia as being an exotic, distant land, and here was a person from this exotic place, and she was treated like a celebrity. And this celebrity had favoured their little village by choosing to live there. So it was an emotionally very pleasing experience, and her master identity went from being the hunchback, which was the identity that was the prevailing one for her when she was in her hometown, to when she was in the European village, her master identity became the Australian, which was a positive identity for her. Now, during this 12 months that she was living in this European village, she got her first job in her life, and it was a physical job, a physically demanding job. So all of a sudden she was working physically for a living, and she got into the first romantic relationship that she'd ever had. And these were two wonderful experiences for her, on top of all the pleasant experience of being a celebrity in this new place and being treated very well. Obviously, she wasn't in any emotional pain. Now, she also reports that on one occasion she fell over and landed heavily on her back, and usually an experience like that would have been enough to render her almost senseless in pain and make her highly disabled for quite a few days. But she reports that she fell on her back heavily and she felt okay. She was slightly bruised, but she wasn't in intense pain as a result of the fall. Now, this whole year is a massive exception to her pain pattern. And unfortunately, the sad part of the story is that when she returned to Australia, her pain came back again. And I guess from a psychological perspective, you can view it as being her master identity just simply returned to being the hunchback rather than being special for positive reasons. And again, she was viewed with a degree of prejudice and disdain by people that were basically unkind to somebody with a physical disability. So she went back to being emotionally distressed at some level. Now, the important thing to recognise in all this is that while she spent the year experiencing this exception, there was no physical change to her back whatsoever. Years earlier, orthopaedic specialists had reviewed her x-rays, and one had said that she had the spine of a decrepit 90-year-old. She had no disc matter left in her spine at all because of the extreme pressure that the shape of her spine put on the disc material. It had basically destroyed all the disc material so that there was none left in existence. And her whole spine was basically just bone on bone, vertebra on vertebra, and the vertebrae were wearing each other out through the constant movement and aggravation. Now, this was the case for her when she was in Europe for a year and experiencing no pain. It was the case for her before she went to Europe, and it was the case for her when she came back from Europe. None of this physical reality changed whatsoever in the year that she was away, or the year that she came back. However, while she was away for the year, she had a whole year of not being in pain, a massive exception. And that is incredibly meaningful. And it is very informative about what was going on in generating her pain. If her pain was being generated by the biomechanics of her spinal deformity, there is no way in the world she could have experienced a year of not being in pain. It's simply physically impossible because her spine did not change at all in the year that she was away. So this really highlights the reality of the psychological factors in the causation of chronic pain. And she's probably the person that I would say was the most physically disabled person that I've seen, the person with the highest level of spine pathology that I've worked with, and even she had a year of not being in pain. The other important exception to, or the example of exceptions that I've included in my book, was the case of Ronald, who had the extreme pain in his chest, which we concluded was a TMS pain of the nerve. So it was an oxygen deprivation, ischemia of the nerve which runs through his chest. And as I mentioned earlier today, Ronald had a high level of deformity in that he had a very large concave in the bones in his chest. And the physical practitioners that were trying to treat Ronald for the chest pain came to the conclusion that it was this physical deformity that was responsible for the pain in his chest, suggesting that his heart didn't have enough room to function without being in pain. However, the obvious exception to this is that he'd spent probably 55 years of his life in an exception pattern to the pain. Now, during the earlier 55 years, he had not had one day in his life of not having the chest deformity, the concave in his chest. But up until he was in his mid-50s, around 55, he'd experienced no pain in his chest whatsoever. That is a 55-year exception pattern, which is, again, incredibly informative as to what's going on. Another client that I had experienced, a woman experienced chronic back pain for about 10 years. And unlike other cases that I've presented in my book, it was taking longer for her to overcome the back pain using the ideas that I've presented. She was using pacing while she was in pain as a way of trying to increase her activity level while she was working on thinking psychologically about her pain. And she reported only one exception to a pain pattern, and it happened a couple of years earlier. For about a minute or 2 minutes while she was in the shower, she experienced no pain in her back. Now again, even though one minute of an exception is an incredibly small time frame compared to 10 years of being in extreme chronic back pain, it's still informative. If her back pain was a result purely of biomechanical forces and physiological and even neurophysiological reasons, then it's just simply not possible for her to experience an exception to the pain pattern, even for 1 minute. If her pain was resulting from, say, disc pathology, then for that one wonderful minute, her disc pathology did not disappear, because disc pathologies can't do that. So the only way of really making any sense of that is that something else changed, something else varied in her whole makeup. What doesn't vary is a disc pathology or a spinal pathology once we've done it. That doesn't vary, it doesn't change over time, but what can vary are the psychological factors that can produce chronic pain. And so even this 1 minute of exception was an important piece of information for her to internalise and to work with. So it's really important for you with your own chronic pain that you look for exceptions and you make a very deliberate focus on trying to look for exceptions. Now, as I said earlier, exceptions may be a complete absence of the pain, or it may be merely a reduction of the pain. Either of those, less pain than what it is that you would expect to experience. Either of those are very important exceptions. Okay, now, just running through my PowerPoint slides here, trying to get a sense of what perhaps we need to address in the remaining minutes. Okay, the notion, some people raise the possibility that when people get better with this approach, it's purely a result of a placebo effect. And this is a valid point to raise, and if they're asking whether this could be a placebo effect, then it's certainly a valid question to ask, and it deserves to be asked. And there's a couple of ways of responding to this. One is that placebo effects don't tend to last. Most of the benefit that people report from physical therapies are probably placebo effects, in that there's simply no evidence when researchers take large samples of people undergoing physical therapy. There's simply no evidence that physical manipulation of the body produces a lasting change to chronic pain. There is certainly evidence that physical therapy works to reduce an acute pain which has resulted from an injury. But when we're talking about chronic pain, there is simply no research-based evidence that lasting relief or a lasting cure of chronic pain results from any physical therapy that's ever been studied. Now, within that reality, there are people that report that their chronic pain decreased, or even for a time went away, and these people aren't lying and they're not deluded. It's quite possible for this to be an actual experience. Now, it may have resulted from, say, temporary alleviation of the pain, may have resulted from the physical manipulation which brought blood and therefore oxygen back into the sore area, and then helped to overcome the ischemia. Now, that's going to be a transient effect. It's not going to be lasting. And it may also have resulted from a placebo effect. So placebo effects are very powerful and very important, and they can result in all sorts of physical improvements in pain or health conditions. And it's quite possible that a placebo effect could be operating with a chronic pain. Again, unless the psychological realities have been addressed or have significantly changed during the time when the placebo effect from the physical therapy is operating, it's quite likely that the pain will come back. Now, if somebody's chronic pain is developing or being maintained from additional layers of psychological overlay, such as fear, anxiety, depression, grief, resentment about the pain, anger about the pain, etc., and these additional second layer of emotions that result from the pain are then feeding back into the whole pain cycle, and then if the person receives a physical therapy which produces a short-term transient placebo effect, then that can operate as a circuit breaker, and it can then alleviate the second layer of distressed emotion which has come about from the pain. So all of a sudden the anger, the resentment, the bitterness, the anxiety, the fear, the depression, etc., can radically diminish as a result of the placebo effect. Then it can create a positive spiral. There's less distressed emotion to feed back into the pain cycle via a psychological overlay, and as a result it could actually cycle the person off in a different direction of feeling emotionally better, and therefore less feeding back into the chronic pain cycle. So that's possible, and it may be that the physical therapy has acted as a circuit breaker, which then creates a shift in the distressed emotions, which then mean that less distress is being fed back into the whole scenario. So that's a possibility, but of course there has to be a psychological dynamic, as I've just described, operating in order for that to occur. Now, is this TMS approach purely a placebo effect? Well, I'm not actually concerned whether it is or not, for the following reason. If a placebo effect is going to operate, it can only operate or work with a condition that has a very large psychological component. If you've become a quadriplegic as a result of snapping your neck in an accident, there is no psychological component to that. There's purely a physical reality that the nerve pathways have been severed from your brain to your nervous system, to your central nervous system, and as a result, you can't move, you're paralysed. There is no psychological component to that reality. However, if a paralysis has occurred because of psychological factors, which does happen, it's rare these days, but it does happen. And there's a British psychiatrist called Alan House who works at using psychological approaches similar to this in helping people that are suffering from what they call hysterical paralysis, which is psychologically induced paralysis. And he helps people to overcome this paralysis through psychological strategies. So if your chronic health or pain or paralysis condition is resulting primarily from psychological factors, then a psychological factor is able to address that. If you want to call that a placebo effect, feel free. But what it demonstrates is what's the point that's being made all along. The point that's being made all along is that most chronic pain and many chronic health conditions are actually psychologically induced. There's a very large psychological component to these conditions. That's the proposition that's being put to you. So it really should come as no surprise that a psychological strategy, and whether you want to call it a placebo effect or not really doesn't matter, but a psychological strategy can actually address a psychological issue and result in an eradication or a radical reduction of that particular health condition. If people want to call that a placebo effect, then feel free, because what it demonstrates in reality is that the condition that has been treated to begin with actually has a very large psychological component. And of course, that is the major contention of this particular approach to dealing with chronic pain. Okay. All right. Well, look, I think we're just about out of time. Because we're running right to the end of the time for which we have this room booked, I don't think we're actually going to have time for questions. But as people have found during the breaks that we've had between the sessions, you're very welcome to come to me when I'm packing up and after the workshop is ended and ask questions of me, and I'm more than happy to spend time answering those with you. So unfortunately, we won't have time for questions and answers right now, but feel free to hang around at the end of the presentation and bring your questions to me. And I'll also, you can see my email address there up on the board. Feel free to email any questions to me as well. Also, just in my final parting comment, please be aware that there's a couple of excellent resources on the internet for addressing chronic pain. One is called the TMS Wiki. The TMS Wiki is a web page that is absolutely chock-a-block full of fantastic resources for people suffering from chronic pain. It's an excellent educational tool that people can learn more about the TMS model of chronic pain. There's also an excellent forum that you can join and participate in, where you'll have the opportunity to ask a whole lot of questions of people that have gone through their TMS journey and for the most part have come out the other side and are very willing to talk to other people and to provide support and assistance to other people that are undergoing their journey of chronic pain to help them to come through it. And the other one is the TMS Help Forum. You can find links to both of these, which again is another excellent forum that you can participate in. Again, asking lots of questions and getting lots of support from other people that actually know what's going on for you. There are links to both of these websites on my webpage. So we'll leave it there. I'd like to thank you for your attendance today and for your attention. It's been a long day and there's been lots of information that's come your way. I'm really pleased by your ability to stay with the process today and to ask a lot of very interesting and pertinent questions during the breaks. And as I said, feel free to hang around and ask any questions. And thank you again, and good luck in your journey.